Good morning, good afternoon. We are starting the session. Timing is everything. We have a wonderful selection of 3 abstracts. These will be wonderful oral presentations, and we are calling to the stage our first presenter, who is Liz. A second to introduce myself, I am Andrea Margulis, and I work with RTI Health Solutions. No.
Click next. Yeah. And then, yeah.
Thank you.
Thank you. I'm happy for the opportunity to share some of my research today. I'll be presenting on whether major congenital malformations, MCMs, are identifiable among claims for non-live births. And these are our disclosures. So why are we interested in this? Well, as many of you know, studies of drug safety during pregnancy often seek to identify MCMs as a study outcome, often the main study outcome, and these can be conducted within the claims data. To ascertain MCMs within claims data, we typically search for ICD-10 diagnosis codes among infant live birth claims. So our objective was to determine the frequency of codes for MCMs associated with non-live births in claims data. And that's a potentially important question because if a drug leads to an MCM, which leads to a non-live birth, and you are restricting to a live birth cohort, you have a survivor cohort, and that may bias your results. However, our objective will be tricky to address for a couple of reasons. The first is that use of MCM codes for a non-live birth on a maternal claim is uncertain. Claims are for billing purposes. And second, ICD-10 guidelines specify that codes for congenital malformations can be used throughout a mother's lifetime. So if we see a MCM code on the maternal claim, it could be for the mom. So keeping these things in mind, we leveraged the Dynamic Assessment of Pregnancies in Infants, DAPI infrastructure, which takes Optum claims data and applies an algorithm to identify unique pregnancy episodes and their outcomes. So we identified 1.2 million pregnancies during our study period and then classified them into live births, ongoing or disenrolled, and non-live births, which of course is our focus today. Non-live births were further categorized into ectopic pregnancies, molar pregnancies, stillbirths, and abortions. And abortions were further classified into induced or spontaneous. Among these non-live births we identified, we then wanted to ascertain MCMs. And to do so, we searched for MCM ICD-10 diagnosis codes within plus or minus 30 days of the non-live birth. And I'll note that we did not include a few things in our definition of MCM because they're likely not directly caused by a drug, which is usually what we're interested in particular, chromosomal anomalies. So when we get to some of the tables showing frequencies of MCM codes and you're wondering why chromosomal anomalies aren't on there, that's why. So 1.3% of pregnancies that ended in a non-live birth had an MCM code within that 30 days plus or minus the non-live birth. And we further restricted to MCM codes that were also not present more than 30 days from the non-live birth. And we did that to get at sort of a temporality of the codes, where if the code was present pretty far away from the non-live birth, it's probably maternal, which in itself is interesting. So sort of the rest of the what we look at here will be just trying to tease apart the maternal and non-live birth codes. And so to kind of isolate these maternal MCM codes, we one of the ways, like I mentioned, that last purple box, that last restriction, was to actually look at these codes that we're pretty sure are maternal and what do they look like. And then the other way was, if you look at the bottom green box, which I'm considering our study population, our main study population, looking at MCM codes during the first trimester, which is a time period where it's difficult to diagnose MCMs, and the codes might be more likely to be maternal. Oh, and I'll mention our main study population was almost 2,400, which ended up being 1% of pregnancies that ended in non-live births have associated MCM codes that were not present outside of the 30 days plus or minus. Okay, and then to try to isolate MCM codes for non-live births, we described the frequency and type of MCM codes during the second and third trimesters, which would be when you may be able to diagnose an MCM, and MCM codes among induced abortions and stillbirths. We also honed in on as outcomes where we would be able to diagnose an MCM, and it may be more frequent. And we examined claims profiles of select pregnancies that end in non-live birth. And so if you picture somebody receives a pharmacy claim for a filled prescription, and then perhaps a couple clinic visits and a claim for a hospitalization, when you put that all together into a claims profile, you can get a sense of a patient's care over time. Okay, on to the good stuff, some of the results. So first, I will talk about this first column, the top 5 most common MCM codes on claims surrounding non-live births. So this is amongst our almost 2,400 main study population, the green box in the flow chart, the bottom green box. We had about 2,400 people, we had about 2,400 non-live births that had an MCM code surrounding it. And you can see that the congenital malformations of the uterus and cervix is by far the most common MCM code. When we tried to isolate the maternal codes out of this, in the right 2 most columns, you can see this Q51 congenital malformations of the uterus and cervix code becomes even more prevalent, particularly in the rightmost column, which we're pretty sure are maternal codes. So now we tried to isolate codes for non-live births, and you can see the right 3 most columns, that Q51 congenital malformations of the uterus and cervix code is still quite prevalent, but not as much. And other codes become more common, such as Q89, other congenital malformations not elsewhere classified. So we wanted to dig further into a claims profile of a woman with stillbirth and MCM code Q89, other congenital malformations not elsewhere classified, to really get at, is this a maternal code? Is this a code for the non-live birth? And what we were looking for were things that could indicate that a MCM could be diagnosed. So, was there imaging? Were there office visits to specialists? And that's exactly what we see. We see 9 days before the non-live birth, we see an echo exam of the fetal heart, which has an MCM associated with it. And then the bottom row, you see the stillbirth is in that Q89 code we were looking for. So takeaways. What I take away from this is that amongst pregnancies that ended in a non-live birth, only 1% had a code for MCM surrounding it. And that strikes me as low. We know that 2 to 4% of live births have MCMs, and that is more common in non-live births. So this suggests MCMs among non-live births are not well captured in claims data. And when we do see MCM codes, we see a lot of congenital malformations of the uterus and cervix, which is a maternal risk factor for non-live births, suggesting that some of these codes represent maternal malformations. And finally, when we really dug for it, some non-live births with MCM codes not related to the uterus and cervix were preceded by claims for imaging and office visits to specialists, suggesting that, although not frequent, MCM codes for the fetus can sometimes be found in maternal claims. So thank you. I would welcome questions, comments, thoughts on further development of this work.
Anyone who wants to ask a question, please come to the microphone here and introduce yourself before the question.
Hello, Jennifer Island, Optum. I'm curious what you think is important here in terms of the questions that we want to answer, and whether it's important clinically to understand the effect of a treatment on malformations kind of preceding live birth, and thinking about non-live birth as competing events and how we typically restrict to live births. And I think there's been a lot of debate recently in terms of what questions we really are interested in asking. And just curious kind of whether you think that these findings have the potential to start to change that discussion around what we can answer and what we should be asking.
Yeah, thanks. I mean, I think that one of the takeaways is that it is hard to look at. I mean, I think we all kind of probably guessed, and then just putting some numbers behind it, that it's very difficult to capture non-live births, MCMs among them, using claims data. So it doesn't give us a easy path forward, but I think there are some maybe golden nuggets in there for, okay, it's not going to be the main part of a study, but if you are already doing a safety study and then want to look at MCMs among non-live births, maybe there are some things we could think about to just do it the best that we can, but just know that there's a lot of limitations with it in claims data. Thanks.
Wonderful, thank you. We are on time to go to the second presentation.
Right.
Thank you. Please, Mengying Lee.
You.
I hope you can find your presentation there.
I will try next, then I'll get it started.
No, we need to come.
Oh,
Yeah.
I think that's why. Do I just click on my name and then slideshow? Okay, great. Thank you, everybody. I'm Mengying Lee from IQVIA. It is a pleasure for me to present our group's work on the validity of algorithms for congenital malformation, particularly in the US real-world databases. And this is a systematic literature review. So these are our disclosures. So a little bit of the context. I think Liz's presentation probably also touched upon this already. Post-authorization safety study play a crucial role in protect public health by identifying potential risks and preventing adverse effects associated with the drug use. In particular for pregnancy, whereas pregnant women are usually not included in a clinical trial, so it's particularly important to for us to conduct past studies for the pregnant population, whereas congenital malformation is an important outcome. So FDA recommends standardized chart review of pregnancy outcomes to minimize misclassification, but this might not be feasible in all cases. So the next best scenario would be, and a more practical one, would be to operationalize the definition of the algorithm in the form of an algorithm to capture the outcome of interest, and then assess its performance in a validation study. When we talk about congenital malformation in a past setting, it's usually the major congenital malformation, simply defined as abnormalities that have medical, surgical, or cosmetic significance. And these CMs are usually classified by organ system, and within the internal organ system, you'll have specific malformations such as people familiar with neurotube defects or oral clips and palates or cardiac defects. Those are some of the common ones. So the objective of the study is to conduct a systematic literature review on the validity of the algorithms to identify overall algorithms for overall congenital malformation by organ systems or specific congenital malformations. And we focus on the US data sources, including claims, registries, and selected surveillance databases. So like all systematic review, literature review, we did a systematic literature search in the PubMed starting 2010, so relatively recent. We did an abstract screening, and then we reviewed the full text of the included ones. And also, to be more comprehensive, we also searched the references of the included full text. The inclusion criteria for the studies include the study has to utilize algorithms for CM in general, for organ system or specific CMs. It has to be based on structured coding system, and it has to be applied in US administrative data sources, as we talked about before. We focused on algorithms that are applied to pregnancies, live births, stillbirths, fetus, and or infants. The study has to have generated quantitative measures of validity, such as positive predictive value. And the exclusion criteria are common to a lot of these studies, such as not having primary data or not having full text available. So we extracted the characteristic of the data, such as the data source, the study population, and a coding system, and also related to algorithm, including what the congenital malformation was assessed, the validation method, the estimates, the sample size, and whether they have actual algorithm. So let's take a look at the results. Overall, we came up with 467 studies from the search, and we retained 118 studies after the abstract review screening. And in the end, 14 studies were included in a review. And this is a summary of these studies. So out of the 14 studies, we have 8 that are from commercial or Medicaid claims data, 4 in different types of registries, and 2 are in vaccine safety linkage, safety data link. 12 of the studies used are based on ICD-9, whereas only 2 are on ICD-10. So there is a lag in the literature where you don't see so much validated algorithm in ICD-10. Most of the studies are in mother-infant pair or in live births, and that wouldn't be surprising when you heard the first presentation, whereas only 1 are in stillbirth because it's difficult to capture, and it doesn't have implications for the past study. We have 68 validation estimates, and the sample size vary between 30 and 4,000. It's a wide range and from very different data sources. A summary of the algorithm's validity. We do find that specific congenital malformation consistently show high positive predictive value. Now I say consistent, given the number of the studies, some of that might not, we want to see more of the estimates, of course, but some of those, the specific CMs are oral clefts, gastroschisis. Those are, I believe, the opening of the front of the abdominal wall, ventricular septal defect, hypospadias, and intestinal stenosis. All of them seem to be either clinical, visually obvious, or clinically require a lot of intervention. And when you look at the data by organ system, we do found that congenital malformation of the orificial defects, and those are clefts, etc., and cardiac defects have consistently showing relatively high positive predictive value. And a general observation, which goes back to the point about fit to purpose, is that the first point is that a congenital malformation of other organ systems and overall had widely varying PPV across studies. For example, if you look at CM overall, you have 6 estimates that range between about 40% PPV to 95%. But some of the heterogeneity might be due to the fact that different types of algorithms are used for different purposes. For example, within the same study, we have seen that using more stringent algorithm, such as requiring multiple occurrences of a code or restricting to inpatient code, reduce the false positive rate, but it does miss true cases. So in the end, it goes back to the question of whether you want to maximize your sensitivity and come back to do a chart review, or if you want to be very specific. So here is a more figurative illustration of the PPV by organ, of the congenital malformation by organ system. And you can see, as we presented before, that the cardiac, but not the overall circulatory, actually. The cardiac defect does generally have relatively high PPV, and here is our official. You can see a lot of these estimates being really high. So conclusions, like we have talked about this throughout, the validity of the algorithm vary by the congenital malformation. We are talking about specific CMs that are clinically apparent at birth or require postnatal repair, consistently show moderate to high PPV, which we kind of took an arbitrary cut at around 70% across different databases. And aside from the orificial and cardiac defect, which consistently show relatively high PPV, algorithms for CMs of other organ systems or CM overall may require further refinement or to be supplemented by a direct case confirmation. And like we said earlier, most of the validated algorithms are in ICD-9 era, so there is really a need for taking us to the ICD-10, and then they're all covering live births only. All right, so the implication is that pregnancy paths may need additional chart review to confirm CM without valid algorithm, and then miscarriages and stillbirths may need to be considered in study evaluating CM outcome. You might want to do sensitivity analysis, including or excluding them, for example. Yeah. So thank you so much. And this is my team. I acknowledge my team and happy to take any questions.
Before we start with the questions, the slides for several of the presentations are available in the app. So if you cannot read because it's too far, too small, whatever, you can look at them perhaps in your phone or your laptop if you have them with you.
Thank you so much. Very interesting presentation. It's Azar Marabadi from Dalhousie University in Halifax. One of the things I'm interested in is I'm researching neural tube defects. And in our province here in Nova Scotia, we have a really old congenital anomaly database that we can link with our information right now. And they've mentioned like just some preliminary analyses that the congenital anomaly that's found in births basically past 20 weeks. So we have here in our provincial database stillbirths and live births, but still, because the diagnosis right now is happening so much earlier, and so on, that for neural tube defects, it's missing more than 50% of them. So I guess I'm just wondering, so knowing that, like, how do you interpret these validation studies? So like in this is really like a PPV.
Mhm.
The way you'd interpret that
That's
is really among those live births. There's no way to, from that, to say how many are missing. Or I guess I'm just trying to wrap my
Yeah.
head around
Yeah.
how you really interpret
Yeah, I
that.
see what you mean. Does the particular, thank you for the question. I have a clarification. Does the particular database that you were mentioning have cover, you're saying all pregnancies after 20 weeks, is that right?
So our provincial database has all pregnancies after 20 weeks. There's like some weight over 500 grams and so on. And the congenital anomaly database is just congenital anomalies. It's 20 years old, and anyone who has a congenital anomaly at
Okay.
any point. So there's pregnancies that are terminated early. So
Mhm.
we're actually missing,
Yeah.
it's a huge number for just for neural tube defects. It's so
True,
I guess I'm
true.
just wondering, like, how
Yeah.
to, when you try to interpret these findings, if it's only restricted to live births, then it
Yeah.
doesn't give you that whole picture of how many are missing. And it made me concerned if I do a study that doesn't use that congenital anomaly database, for example, I'd be missing so many.
Yeah, I think it probably goes back to the database. If you are thinking about, and of course here we had made a lot of aggregations, and then it does vary by database, but I'm thinking if you are thinking about this, the process, if you are thinking about maybe claims data where if you are focusing on NTD, for example, and maybe you can look at the diagnostic data to see whether they have any that are diagnosed prenatally. But I agree that if you only focus on live births, it's going to be greatly underestimated. Yeah, thank you for pointing it out.
Any other question?
Quick question or
Mhm.
comment. You may
Mhm.
want to, maybe you have done that. You may want to
Mhm.
consider looking at the time of follow-up that was used.
Yeah,
I mean, you pointed
that's a good
already
point.
out
Yeah.
that, the malformations that are blatant
Mhm.
probably also have a high PPV, but,
That's true.
so
Mhm.
typically, if you look at these timelines,
Mhm.
it takes about 6 months at least until the major bulk of malformations have been identified.
Mhm.
And
Mhm.
there may be different follow-up time in those studies.
Yeah, that's a
Might be
good.
interesting to slice
Yeah.
that.
Thank you. Yeah, that's a good suggestion. The other thing, I think there are definitely a lot more granularity in these data in terms of how far out they assess this kind of data. And I believe there has been a poster that we're assessing, for example, cutting the assessment period to, for example, 60 days after the birth, whether that sacrifice a lot of the completeness, for example, that are captured, and other things like what kind of algorithms are used and whether you use inpatient and outpatient. I think we didn't present a lot of the granularity, but definitely there are things that's worth diving into it. Yeah, thank you.
Thank you very much. We call our next speaker, Sarah Hoffman.
Thank you. My name is Sarah Hoffman. I'm a research scientist at Carillon Research, and this is identifying pediatric patients for an external control arm using multiple administrative healthcare data sources, lessons from the road. This study was funded by Pfizer, and multiple co-authors are Pfizer employees or have other relationships with Pfizer. This could have easily been an hour-long talk, and I will do my best to get it in 10 minutes, which means that I'm not going to read every word on every slide, but the slides are downloadable, and there is a ton of really interesting supplemental content at the end of the slide deck as well. As many people in this room probably know, rare diseases pose unique challenges to trial design and implementation. Single-arm trials with external control arms have been accepted by FDA as support for new drug indication approvals. And in fact, FDA released earlier this year a draft guidance on externally controlled trial that actually focuses on the use of real world data for constructing the external control arms. Our study focused on pediatric relapsed or refractory cases of a specific genetic subtype of a rare form of lymphoma. And we constructed an external control arm using real world data for 2 clinical trials that began in 2009 and 2011. Those trials were exploring the use of an existing agent for this indication in pediatric patients and had no comparator groups or control group. The purpose of our external control arm was to characterize the outcomes in those patients who were qualified to be in the trial but were not in it. And we actually looked at contemporaneous patients. So we were looking at the real world data that went back to the time of the actual trials. Unfortunately, however, we were not able to complete the study due to lack of eligible patients, as you will see. So the objective of this presentation is to describe the process that we went through in constructing the protocol and identifying the patients and all of the things that we learned during that endeavor. In short, briefly, the methods, we had 2 U.S. administrative healthcare databases with a combined 160 million plus patients with access to health records. We applied a screening algorithm to the structured elements of each of those databases, and then we had expert clinical adjudicators look at the medical records to confirm patient eligibility for the study. In all, we found fewer than 5 patients who had the indication of interest at the time of the clinical trials who were not in the trials during the study period. And so the study was not able to proceed. An attrition figure is available at the end of the slide deck in the supplement. There were 3 general types of challenges which are interrelated and often overlapping. They were substantive, methodologic, and administrative challenges to carrying this out. The substantive challenges mostly stemmed from the nuances of the indication. Structured data alone were insufficient to determine eligibility for this study, which meant that we had to get expert adjudicators, go through medical record acquisition processes, and review the records, redaction, adjudication, that whole process, which is resource intensive, just to be able to find out that we didn't have enough patients. And this is an important point because I think that if one is going to invest in a study protocol, which requires a lot of resources back and forth to finalize it, it is nice to know before you invest all those resources in the study protocol, whether or not the study is even feasible. So after this experience, we recommend that if you have a rare disease that cannot be identified through structured data alone, perhaps consider having a mini protocol and go through the medical record process to see if the study is feasible before you invest in making a larger protocol for the whole study. And part of why we couldn't use structured data to identify these patients was that there was not sufficient genotype information in the ICD coding systems. In ICD-9, it was not available at all. And in ICD-10, we did have genotype-specific information, but it was inconsistent even within the same patients, as well as not being validated yet in the literature. And ultimately, just the rareness of the disease, even with all the data in the world, we may not have been able to carry out the study. Methodologically, a key challenge had to do with covariates. You'll see challenges 1 and 2 are both covariate related. First of all, we have to distinguish the effect of the drug versus the effect of trial participation. The confounding structure and the covariates that we might be interested in as epidemiologists may differ from a typical pharmacoepi study where we have drug A versus drug B, both prescribed in a clinic in the real world. What we're thinking about now is, why did this patient not participate in the trial? What might some covariates that relate to that be? So it's a slightly different DAG, and one might want to collect different covariates than originally thought. And this relates to point 2, which is that the covariates, the confounders that we were interested in, were not all available in the trial data. And if you think about it, this makes sense because a single arm trial is not planning to do a comparison, let alone with real world data. And so those pieces of information were simply not collected. And this relates to a point that's in my final slide of recommendations, which is the point that the FDA's draft guidance is really emphasizing, which is plan your external control arm when you write your trial protocol. That way you make sure that you're collecting those relevant confounders. There's also the issue of outcomes not being consistently available in the observational and trial data. They're simply measured different ways. We had to find ways to operationalize all of our outcomes in the real world data, which was actually really interesting, but also challenging. Additional considerations methodologically, I want to emphasize the last bullet, which has to do with when we start follow-up. In the pharmacoepi world, we typically begin follow-up on the date of treatment initiation. We have incident new users, we have an index date that's the first claim for some drug after some look-back period. But in the trial, the start of follow-up may be the date of enrollment in the trial, the date some certain eligibility criterion was met, and that's not the same. So there is a slide in the supplement that shows how this can result in immortal person time in the trial cohort. And so it's very, very important to make sure that when you look at your trial data that you have the dates that you need. And ideally that you plan to record the date the treatment was actually started in the trial participants. Administratively, there were a number of challenges, all surmountable. And one of the issues was the lack of availability of the trial data for the study planning. As many people in this room probably know, trial data are strictly controlled, and so they may not necessarily give you access to it when you are writing your study protocol. And this relates to point number 2, which is that instead I was given a data dictionary, but I was not familiar with the conventions of how the trial variables were named. And the data dictionary was basically in a language I did not know. And on the other side of the coin was the fact that the trial analysts were very curious as to why I was even interested in having certain variables, which brought me back to the DAG and explaining how we think about confounding as epidemiologists. So there was room to learn on each side, but it's important to build that into the timeline, especially if it's the first time that the two teams are working together. And finally, I want to point out, it is the second to last bullet, that medical record expert adjudicators, they may recognize the cases that they've treated during their medical record review, even if you've cleared out the name, date of birth, identifying information about the patient. These are patients with a rare disease, they are children. The clinicians are probably going to remember, oh, I remember that patient. They had this tumor, it progressed this way, and it had this outcome. So the anonymity is no longer there. And so it's important to write that into your IRB applications so that you can address it up front. In conclusion, the challenges I believe would have been surmountable, but we weren't able to demonstrate that by actually doing the full study because we simply did not have enough eligible patients. Our recommendations are to read the FDA draft guidance and the EMA reflection paper on this topic, and make sure to build your external control arm into the actual trial protocol. Remember, we did this 10 years after the trials began, so we had no control over what data were collected in the trials that we might be interested in. So by having the epidemiologist sit down with the trial team and help draft that trial protocol with the real world external control arm built in, it's going to make for a much easier time and probably a stronger study. Budget additional time for communication and learning between the epi and trial teams, and definitely plan your feasibility assessment, possibly even before you begin writing the trial protocol. And that is it. Thank you.
Wonderful.
Hello, Christian Ham from Regeneron. I appreciate you coming here and bringing kind of a lessons learned talk. I think there should be more of those. My question is, so you said you identified fewer than 5 patients who met the criteria but were not in the trial, correct? Did you also come across patients who were in the trial? This may be an imperfect measure, but gives you some idea of the sensitivity of your approach.
Yeah, we did identify patients who were in the trial, and that's actually comforting because it means that our structured data screening algorithm and then medical record review worked very well. Yeah. I don't remember the number off the top of my head, but it was more than one. Yeah,
Thank you.
welcome.
More questions? Do you have an idea of
Where is that coming from? Oh, it's you.
the, yeah, the ghost voice? And do you have an idea of how much one would have needed to relax the eligibility criteria to get to a number that would be valuable?
You mean expand our eligibility criteria to get a larger number of patients? I'm not sure.
For if you didn't need very specific data on the tumor, the more specific minor details of it, would that have been enough for the numbers? I know that the patients then might have not been necessarily good, but I'm trying to understand which bits are of relevance in this sense.
That's a good question. And actually, it wasn't very many patients that we even had who were eligible with the very broad screening algorithm on the structured data. There were only 134 potentially eligible. So we were allowing for any genotype. It was very, very broad, that screening algorithm. And then out of those 134, only 74 had medical records available. So I think one of the bigger parts of the attrition, if we look at the attrition slide, I will not show it because of time, but basically, I think it was the medical record availability was a huge thing. And yeah, there's a slide in the supplement with the attrition. Yeah.
That's interesting, and it affects, I guess, not only this type of study, but also any validation study for which we may want those records. And what was the anticipated study size?
I think we wanted to at least get 25, maybe 10. We were expecting maybe 25. That was the end goal. Yeah. So it wasn't going to be big at all. And we were planning to use small sample size statistical tests and methods. So we were anticipating that it would be small, but when you have fewer than 5, you can't do anything. Yeah.
I have one more question. Having collaborated with your team, I know that there are quite specific rules for masking numbers in cells with small
Yeah.
counts, and this would be such a big issue. How would that be handled here?
So we actually had recently changed the rule. So right now it's cell sizes less than 5, which still means we can't even say how many patients we identified. But before it was less than 10, and I believe we had talked to our regulatory ethics lawyer person and were able to, I think, get an exception. So sometimes we're able to get exceptions for rare diseases. Yeah.
Would the exception operate for sharing your results with regulatory agencies and the clients, any coordinating center, if there was any dissemination with the public?
Possibly. That's a question for her. I go to her for everything. I actually don't know. Yeah.
Thank you.
Thank you. Thank you so much.
Okay, next we have Dr. Tuitai.
Good afternoon, everyone. Can you hear me okay? Right. So today, on behalf of our team, I'm sharing our simulation study about triple challenge, small sample size in both exposure and control groups to scan for rare maternal outcome in a signal identification approach. This study was funded by FDA. However, this presentation does not represent the view of FDA. So in a pregnancy research, typically we're facing the challenging of have a small sample size in the exposure. And when we think about the study design, typically we consider an active comparator design. And this leads to another challenge that we have small sample size in the control group as well. And our outcome in pregnancy research typically also rare. So given those challenges and the lack of safety evidence of pregnancy research, how can we do a signal identification study for pregnancy research to enhance our safety evidence? So one of the signal identification method is tree scan, which consult a broad scan approach to generate new hypotheses about exposure outcome relationship. And I will have a brief overview about tree scan in the next slide. But here I want to introduce the problem how we want to use tree scan into pregnancy research. So the Poisson tree scan analysis, how we set up the study is we use the control group to calculate the background incident proportion. And from this background incident proportion, we calculate the expected event count happen in the exposure group. And one assumption of the Poisson method is that the calculate expected count in the exposure group had to be known without any error. So this leads to a potential problem that when we have a small sample size in the control group, our observed background incident proportion may be imprecise, and this could lead to affect tree scan ability to attack potential signal as well as control for type 1 error. So we conducted our simulation study to quantify those impact as well as try to answer. So how big the sample size in the control group we would need in order to do the tree scan analysis. So this is a little bit overview about tree scan. It's a data mining method that can evaluate thousands of outcomes at the same time to identify potential adverse events. And those thousands of outcomes are structured into a hierarchy called tree with multiple levels. And in tree scan, it does not require the user to select a specific exposure outcome pairing for hypothesis testing, and it can adjust for multiple scenarios. And let's move to our simulation study. We use the market scan data to calculate the background incident proportion by forming a single live birth pregnancy among the pregnant person aged 10 to 54 years old, and those pregnant person exposed to either oral macrolide or penicillin. We use the ICD-10 chapter, pregnancy, childbirth, and puerperium to build a maternal outcome tree. And we evaluate maternal outcome from 1 day after the first antibiotic pill date until 30 days after delivery. And the way that we calculate the true background incident proportion for each outcome in our tree is the total incident outcome among the macrolide or penicillin user divided by total pregnant person exposed to either macrolide or penicillin. We set up our simulation study in two main teams of scenario. First one under the no scenario, where we vary the sample size in the control group as well as the sample size in the exposure group. And all outcome in the tree was set with a relative risk of 1. In the second scenario, under the elevated risk scenario, we choose similar parameter for the control sample size and exposure sample size. We further select 3 maternal outcomes with different incident proportion, one very rare outcome like 0.05 and one like less rare outcome 0.01 and more common outcome 0.02. And for each of those outcomes, we injected with a relative risk of 1.5 or 2. And for all other outcomes in the tree, we set with a relative risk of 1. So overall, we evaluate 140 scenarios. And this slide shows how we set up the analysis for each scenario through 4 steps. In the first step, we calculate the expected event count in the exposure group by 2 ways. First one is under like the perfect scenario, our base case or true. So the expected count was equal the product of the true background incident proportion and multiplied by the sample size in the exposure group. In a second way, we calculate when we use the simulated imprecise background incident proportion. So the expected count was the product between the incident based on a Poisson draw given a sample size in the control group, and then we multiply by the sample size in the exposure group. In the second step, we calculate the observed count of the outcome in the exposure group by doing another random draw of the product among the true background incidence proportion, the sample size in the exposure group, and the relative risk of that particular node. And in the third step, we implement all those calculate observed expected count into tree scan and run a Poisson tree scan analysis with an alert threshold at p-value less than 0.05. And we repeat step 1, 2, 3 for 1,000 iteration. In step 4, we aggregate all the tree scan output of those 1,000 iteration and report the following result. First, when we evaluate a node scenario, we report the Taiwan error, which was the proportion of iteration with at least one alert among 1,000 iteration. We also report the mean number of phone alert. And second, when we evaluate the elevated risk scenario, we report the node-specific power, which was the proportion of iteration having the injected node as an alert. So let's move to our result. So this one shows our node scenario, and row highlight in red here as under our true. So like we use like perfect like scenario. So we can see that the Taiwan error was maintained around 0.05 and the mean number of phone alert was less than 1. It's right. So however, under the imprecise incident proportion, we observe an inflation of Taiwan error. And if we fix the sample size in the exposure group, what we observe that when the sample size of the control group increased, there was a decrease in Taiwan error. Or in another way, when we have a higher ratio of exposure sample size to control sample size, we have more inflation in Taiwan error. And similar like result was observed for the mean number of phone alert. So let's move to the second scenario where we have the elevated relative risk scenario. So the x-axis represent for the ratio in the sample size between the control group to the exposure group. And the y-axis represent for the difference of the power for a particular node that we injected the risk between the imprecise background incident proportion compared to our base case. And the like shading orange like box represent where is the tolerable range in the difference in power within 0.05. So we can see that like around like the left corner, like we have like observed more like the difference in the power more likely to outside the box. It means that when we have a small sample size in the control group, like our observed like power would be more likely to be incorrect. But when we have a control sample size was substantially larger than the exposure size, the difference in the power was within the orange box. So overall, what we found is the imprecise background incident proportion generated by a small control group lead to an inflation of Taiwan error as well as an increase of phone alert under the node scenario. And under the elevated risk scenario, we observe the change in outcome specific power in both directions. So ideally, when we do a tree scan analysis, the control sample size should be several times larger than the exposure sample time. And if I have a very small control sample size, and if I want to use the Poisson tree scan analysis, I should be like interpret the result with cautions, or I should need to take other measures to mitigate those issues as much as possible. And thank you. I'm happy to take any question.
Thank you, Joey. We've got a few minutes for questions. While we wait for inspiration, do you have I don't use TreeScan. I haven't used it before. Do you have an example exposure outcome pairing where we might expect to see this problem? Is this a case where an indication is rare and there's only one treatment for it? Or is there an intuition for how we might expect to see this in data?
Yes. So like, for example, typically like, I can pick any. So like, for example, another, one of like, aim of the project that we compare like something really common, like we compare like Marolide directly to penicillin, right? For Marolide and penicillin, and typically we know that like penicillin is use more common than Marolite, but typically it's not like several times larger than Marolite. So even though like Marolite and penicillin as one of the most common like drugs used during pregnancy, we're still facing the similar challenging. So it's really depend on how we choose the control in our design, and it's really depend on the research question. And because typically like when we design it, we want to choose a perfect control group like to mitigate like a bunch of the control or bias in our design. And when if we restrict too much in our control group, and it's may lead to our sample size of the control group become like really small. So in that situation, we may need to like relax like our like design a little bit, because this is a signal identification approach. So we may like have to like switch to a different control drugs, or in some scenario where we cannot find like a perfect like or a big enough control sample size, we still may need to consider the non-user design as well. Yeah, but we need to wait between like the risk of the bias and like the issue of the small sample size in the control group like in this approach.
Thank you. Okay, thanks so much. Please welcome our next speaker, Dr. Yoo-Seon Jung.
Good afternoon, everyone. I'm Yoo-Seon Jung, a postdoctoral researcher from Chungang University in Korea. It's a great pleasure to present our work here in ISP. This work was collaboration with a rheumatologist and an OBGYN from Hanyang University. This work was about a factor associated with abortion of women with systemic lupus erythematosus with the focus of drug utilization. This is funding information, mostly public funding. So I will start from the little background. What is systemic lupus erythematosus? In short, it is lupus. I refer it as lupus throughout the presentation. Lupus is a chronic autoimmune disease prevalent in women with childbearing age. As other autoimmune diseases, it comes with variety symptoms from butterfly rash to organ damage, including heart, kidney problem, and arthritis. The treatment goal of this patient is to control disease activity and minimize damage to the organs. And women with lupus have a higher risk of abortion than general population, as high as 4.7 times. And pregnancy itself can cause increases in this disease activity, and disease activity increase the risk of adverse pregnancy outcomes. So management of disease activity before and during pregnancies is also really important for this patient to have a better pregnancy outcome. For the medication management, hydroxychloroquine is a mainstay of for disease control in pregnant women because of its minimal teratogenic effects while controlling for disease activity. Current guideline strongly recommends that patients who are already exposed to a hydroxychloroquine before pregnancy should continue on the therapy for better pregnancy outcome. And guideline only conditionally recommends patients without previous exposure to hydroxychloroquine to start on medication with conception. Medications such as methotrexate, cyclophosphamide, and mycophenolate mofetil and rituximab are recommended to discontinue even before the 3 months of conception before. And they are ideally recommended to switch to pregnancy-compatible immunosuppressant. At last, patients with lupus are recommended to prescribe with aspirin to prevent adverse pregnancy outcomes. So current literature of adverse pregnancy outcome often involves single institutional study with small number of patients because lupus is a relatively rare disease. Also, information about abortion is very hard to capture. So the study of abortion in pregnant women with lupus has been very limited. Therefore, we aim to conduct a study using a national-wide claims database in Korea. And our main research question was if the use of hydroxychloroquine, aspirin, and pregnancy-incompatible medication used before and during pregnancy affects the risk of abortion. We used the National Health Insurance Service database in Korea from 2002 to 2018. It covers over 97% of total population, and we're very lucky to have all numbers of lupus patients in Korea. So we have pretty large sites for the lupus patient, and the database provided socio-demographic information, diagnosis, details of treatment and prescription information, including in and outpatient settings of all healthcare entities. We conducted a nested case control study, including pregnancy episode from 2005 to 2018 and history period from 2002 to 2004. At the pregnancy start, cohort was included and followed until the pregnancy endpoint or the data availability 2017 with a year of washout period. The maternal characteristic as age, insurance level, comorbidities were examined during a year before our pregnancy start, and main exposure of drug use was examined during a pregnancy period. A lupus flare, which is really important for the lupus patients during pregnancy, was examined from 3 months before conception to the first trimester of pregnancy. We have included pregnancy episodes from 15 to 49 years of age at a pregnancy endpoint, and diagnosis of lupus defined as having diagnosis code and rare intractable disease registration code. We also included episode with any lupus-related visit at least a year before conception, so we can ensure the presence of lupus diagnosis before pregnancy start. We have excluded pregnancy episode with following criteria. So abortion was captured using a broad terminology using ICD-10 codes, and fetal loss fewer than 20 weeks was also we categorized as abortions. To increase the specificity, pregnancy algorithm adapted to Korean claims database was used to determine the pregnancy outcome and last menstrual period. Cases were compared to controls group, including episode with live birth and stillbirth. The patterns of hydroxychloroquine was examined with 3 months before and during pregnancy. We have categorized the exposures as following categories because in addition to current guideline, patients with already at high risk are prone to be prescribed with hydroxychloroquine or aspirin before the pregnancy start. So we subcategorize as patients who exposed before conception and who are not exposed conception. Also, we wanted to examine the pregnancy incompatible immunosuppressants before conception as well as the first trimester. Covariates we assessed were patient-related or SLE-related factors that include a maternal demographic information, comorbidities, and previous pregnancy loss, and SLE-related factor mostly reflected in the SLE flare during the first trimester. And those are the risk factors that were listed in your LER guideline. We referenced it. And covariates, for the SLE flare, to reduce indication bias, we have really focused on the severity of lupus disease, but it was using claims database, it was not easy to examine the severity. So we found one claims database, one previous published definition of flare in claims database. So we use this operational definition with medication use and healthcare utilization with specific diagnosis. Therefore, most of severity of lupus were captured and reflected in this variable. Yet there's possibility disease activity before conception could not be completely captured with this definition. Multivariable logistic regression was conducted to observe the risk of abortions, and subgroup analysis with a different group was conducted. After inclusion and exclusion criteria, we were ended 4,880 pregnancy episode with 3,059 patients. At the baseline, as expected, the average age was higher in abortion outcomes and controls, and patient with abortion had a higher prevalence of depression, hypertension, hypolipidemia, antiphospholipid syndrome, and etc. And among the abortions, lower proportions of first-time pregnancy episodes was observed. Patient with abortion had a higher prevalence of lupus flare during first trimester, and higher prevalence of pregnancy-incompatible immunosuppressant use was observed before 3 months and during the first trimester. Also, patient with abortion had a higher proportion of hydroxychloroquine use before conception, and those patients who discontinued during pregnancy and those who maintained during pregnancy was both higher in abortion population. When adjusted for their maternal age and lupus flare and different comorbidities, the use of pregnancy-incompatible immunosuppressant before 3 months and during first trimester both affected abortion risk to be increased. And compared to the group of patients who exposed and discontinue the therapy during the pregnancy, all of the patients who exposed, maintained, or who are not exposed at all had a reduced risk, which means patients who are exposed and discontinued are having a higher risk. And patients who are not exposed to the aspirin at all before or after during the pregnancy had a higher risk of abortion. For the subgroup analysis with different age group, use of hydroxychloroquine was more important for patients of 30 years or older, and no use of aspirin was associated with increase in patients with younger than 30 years old. When stratified by the presence of flare during the first trimester, especially group with flare has shown increased risk of abortion when aspirin was not in use. When stratified by the presence of previous pregnancy loss, use of pregnancy-incompatible immunosuppressant during first trimester were not significant, which we interpret as appearing having more cautious prescribing in this population with a large confidence interval. And no use of aspirin was associated with significantly increased risk in episode with previous pregnancy loss. In conclusion, aligning with a current recommendation, the hydroxychloroquine use before and discontinuation was associated with higher risk of abortion as other adverse pregnancy outcomes, and no exposure of aspirin was associated with increased risk of abortion. Use of pregnancy-incompatible medication, immunosuppressant, before 3 months was associated with increased risk of abortion. And the subgroup analysis focused on a certain population, like more age group 30 years or older, were more important for the use of hydroxychloroquine and aspirin with the patient who are risk for flare and previous pregnancy loss experience. In conclusion, appropriate medication use and may decrease the risk of abortion in pregnancy in women with lupus. And I hope this evidence could facilitate family planning more actively and medication management in patients with lupus. Strength and limitation of this study is a large population-based cohort study, and we use the pregnancy algorithm adapted to Korean claims database, but inherent to the Korean claims database, we could have a misclassification bias for the abortion outcome. Definitely, we are planning on to do more sensitivity analysis using a procedure code, which is available in Korea. And for the exposure, we have conducted different definition of 2 or more prescribing as a defining exposure, and we had a similar result to this before. And missing information and lifestyle factors cannot be accountable for the claims database, and intentional abortion could not have been completely eliminated. We have tried to remove the induced abortion using ICD code and a procedure code, but still there could be miscoding could be included. Thank you for the attention and having any questions.
Thank you for an interesting talk. The floor is open for questions. Great.
I'm wondering, you said it's a nested case control study. And I may not have, and I may not have caught this. You said it's a nested case control study. What was the nesting portion? What did you nest this in?
We have so lupus diagnosis patients were nested in so we actually had a cohort of whole pregnant patient with lupus diagnosis. We followed all of the study outcome, including a stillbirth, abortion, and preeclampsia and other outcomes. So it was originally cohort study. So it was originally a cohort of lupus diagnosis.
Okay, but what I'm trying to get at is, usually in a nesting, you're matching on something related to time. And so what you have here is you have abortions, and then you have stillbirth or live birth, and you're looking in terms of your exposure, you're looking at the first trimester. In your abortions, not all of these abortions will have gotten to the end of the first trimester. So you have a different time period. You are ascertaining your exposure variable. So by design, your abortions will have less time to accumulate exposures to anything.
Yeah.
And so you could actually do a nested case control study where you're matching on the time of the abortion, so that you have equal follow-up time in your groups, and that would give you a less biased estimate.
Yeah, I think that could be, that is very good suggestion. And I think we'll put it into the consideration. Thank you.
I have a question while everybody else is waiting for inspiration. You excluded induced abortions from the sample?
Yes.
Is there any concern that people who are having active lupus and aren't able to tolerate being pregnant might choose an abortion rather than continuing a pregnancy? Are you worried about that?
Yeah, that's why we excluded induced abortion, because we had similar presentation in lupus committee. Conference, and they were very concerned about threatened intentional abortion, and because they use the methotrexate itself for the abortion as well, so we had to exclude those intentional abortion to see the other effects.
Yeah, I'm thinking maybe it's possible that the medication use before the induced abortions might be different than, aside from methotrexate. I'm worried there might be a selection bias with the induced abortion as a competing risk, potentially.
Yeah, that could be with the disease severity. Yes, definitely. Yeah, that competing risk to be considered. Yeah, thank you.
I have a quick question. Yes. Are the ICD-10 codes used in your data source very different from the WHO codes or the US version? Are they very different?
Yeah, they are very different. We have actually adapted some of the algorithm that's we reference it from the American, US or other countries' algorithm. We have noticed that some of the advantages, like for the aversion, we have a procedure code with a gestational age range. So that could be a very positive thing for Korean claims database. But other thing was we don't have a gestational age coded in Korea. Unlike I believe in America, you guys do have it. Didn't start from the beginning, but you guys recently have it. And we had also changes in the after a certain year, we have more subcategorized with the specified gestational age coding difference after a certain year, I believe. So we, in Korea, it's a little bit different.
Okay, I think that's all we have time for. Thank you.
Thank you.
Please welcome Dr. Almut Winterstein.
Yeah, thank you. And thank you to everyone for hanging in. What did I do? For hanging in here on a Sunday afternoon. I'm a Mac user and I always screw up PowerPoint. There. All right, so this is the title, No Time to Lose, Prenatal Exposure to Teratogenic Medications and New Abortion Laws in the United States. This is a purely descriptive study. The impetus was really to get these numbers out somewhere, hoping that lawmakers and regulators might consider them. So there's no funding involved in this study. Those of you who have followed the abortion law issues in the United States might know that a year ago, the Supreme Court revoked the right for abortion in the United States and leaves the decision now to the individual states in the United States. And that has resulted in this map you see here. So there are some states that have banned abortion entirely, no exceptions. There are some states that allow some exceptions, such as rape. There's no state that allows exceptions that have to do with malformation or teratogenic exposure to medications that might cause malformations. And some states have different cutoffs for abortion. So, for example, there may be you can abort up to 6 weeks of gestational age or up to 15 weeks of gestational age. Now, with regard to exposure to teratogenic medications, that has some implications. We know that in the United States, about 1 in 16 pregnancies is exposed to teratogenic medications. So with the potential of basically developing severe malformations that might eventually terminate a pregnancy or that might result in a live-born baby with significant problems. So the mandatory risk mitigation programs that might prevent exposure to teratogenic medications only includes 12 medications in the United States. So the majority of drugs don't have really any specific risk mitigation program attached to them other than, some patient information that says you shouldn't take this during pregnancy. So if prenatal exposure occurs, what that means is that the timing of prenatal care initiation is absolutely critical because women might miss the time that they can still abort, which would basically mean that they have to carry a pregnancy to term, even if it is not viable. And obviously that can result in incredibly horrible situations for women. So the objective here was to quantify this, to determine the prevalence of prenatal exposure to teratogenic medications across gestational weeks relative to the timing of prenatal care initiation and legal abortion cutoffs. So we took market scan data, so a population of privately insured patients in the United States from 2017 to 2019. And then we identified 137 medications with known teratogenic risk that was based on monographs that have identified this as such, specifically TARIS. We excluded sex hormones, infertility treatments, opioids, methotrexate, misoprostol, which are teratogenic but are also used to abort, ergotamine derivatives. So we really tried to focus on kind of the bread and butter teratogenic medications that women might be exposed to inadvertently during pregnancy. So common medications are listed here. So we measured that in 2 ways. We only focused on the time period from conception to pregnancy end. So we didn't look at the time period between LMP and conception. We identified either administrations of medications that are teratogenic in outpatient practices or prescription dispensing. And we required that to be in a specific risk period that would impose a teratogenic risk. So for example, for ACE inhibitors, we only looked at the 2nd and 3rd trimester, but not at the 1st trimester. And then we did a sensitivity analysis where we also considered medications that the entire day supply that was provided, or the half-life of the medication that was administered. So in the first analysis, we are only looking at the specific dispensing or administration date in the relevant trimester, and in the sensitivity analysis, we're considering residual day supply as well. In terms of measuring prenatal care, we used an established prenatal care measure that is used by the Centers for Medicaid and Medicare Services in the Child Core data set. That looks at specific CPT codes or pregnancy diagnosis associated with specific provider specialties such as obstetricians and PCPs. So then we basically timed the whole thing based on gestational weeks. So for each gestational week, let's say week 12, we basically looked at the proportion of pregnancies that were exposed to a teratogenic medication up to that specific time point. Then we looked, we had 3 specific categories. The first would look at the proportion of those pregnancies that were exposed to a prenatal medication where the prenatal care preceded that exposure. The second, where the prenatal care came after that exposure, but still within that week cutoff that we're interested in. So basically this would give us here all the pregnancies that were exposed within the first 12 weeks of gestation and where the exposure to a teratogen was before the prenatal care initiation. And then the last category was where the prenatal care initiation trailed that particular week entirely. So that would be the scenario where the discovery that women might have been exposed to a teratogenic drug basically comes after the specific abortion cutoff that we are interested in. So here are the results. We had a total of 5.8% of pregnancies that had that ended in a live birth exposed to a teratogen, and 3.1% of non-live birth. Non-live birth looks smaller because it's a smaller time period than I can get exposed to anything. If you normalize this by the time that is available, live birth, of course, have a larger proportion of exposures. In the sensitivity analysis, those numbers go slightly up because we are considering the residual day supply. And then we have the percent of live births that had actually a prenatal care visit at all, which is very similar to national numbers, 94.9%. And then for the non-live birth, obviously a much smaller proportion. So the distribution across gestational age is displayed here. Dark blue is the first prenatal care visit. Light blue is the distribution of first exposure to a teratogen during pregnancy. We see that for the teratogen exposure, there was a blip at the beginning. So that's clearly the unintentional stuff where women might not even know that they're pregnant, but then it basically continues throughout pregnancy for the live birth. For the non-live birth, obviously, it's all front-loaded in the early weeks of gestation. For the first prenatal care visit, we see that this is also a little bit delayed, obviously not at the beginning of pregnancy, and then has a long tail for the non-live birth and for the live birth. And then for the non-live birth, we see already that those two distributions are basically in opposite directions. So prenatal care clearly comes after the teratogenic exposure. And that's how that looks like. So these are the 3 major abortion cutoffs that are used in the United States: week 6, week 15, and week 22 in the abortion legal abortion rights now. So if we're looking at week 6, about a quarter of all pregnancies that have teratogenic exposure throughout gestation, a quarter of those happens up to week 6, so really early. About half happen up to week 15, and about 2/3 happen up to week 22. And if we're looking at all pregnancies, 1.3% of all pregnancies have exposure to a teratogen within the first 6 weeks of pregnancy. So this is a very busy slide with a lot of numbers, but that's also the most important slide. So dark blue is basically our first scenario where we have the first prenatal care visit before the teratogenic exposure. So that's the scenario where there could have been some discussion where the obstetrician might say, you really need to change this drug and so on. So here's time for prevention. The light blue is where the prenatal care came after the teratogenic exposure, but before that particular week. So in the first scenario, before week 6, so that there could actually still be a discussion whether the pregnancy should be terminated when it is discovered that there was exposure to a teratogen. And then the gray is everything is too late. That's the no time to lose portion, where essentially the prenatal exposure happened and there was no prenatal care before that particular week of gestation we're interested in. So what we see for a woman who lives in a state that has now a legal abortion cutoff of 6 weeks, the vast majority of these women will have had their exposure to a teratogen before, and they would have not have prenatal care initiated, specifically 77% of all live births, and 94% of all non-live births would have not had prenatal care within 6 weeks of gestation, and their prenatal exposure has already happened. As you move down in week 15, This concerns still more than half of all pregnancies, so only 40% of pregnancies had prenatal care before the exposure to a teratogen, and we still have a pretty good amount of gray here. So this is where the prenatal care started after week 15 among those women who had exposure to a teratogen. And even with 22 weeks, there's still something that we need to fix because, again, these women basically have no option anymore and would not be allowed to abort anymore when the prenatal exposure to a teratogen is discovered. This actually looks a little bit different across different medication classes. So what you see here is the distribution based on exposure to teratogenic anticonvulsants versus antihypertensives versus anti-infectives. The dermatologic one, that's isotretinoin here. So you see even for isotretinoin, a good amount of the prenatal care starts after the exposure. And again, these would be women who had been exposed. This is week 15. So these are women who have been exposed to isotretinoin and would not be able to abort any longer if they live in a state that has this law in place. So summary, pretty straightforward. Almost 1 in 5 pregnancies did not have prenatal care during the first trimester. The large proportion of teratogenic exposures occurs during early gestation, about half within week 15. And that means there's limited opportunity for many medication management decisions involving teratogenic risk during the etiologically relevant time window. Prenatal care typically trailed behind prenatal exposure, but also behind earlier abortion cutoffs. So if a potential for teratogenic effects become apparent, most pregnancies would need to be carried to delivery based on more restrictive laws. So the solutions, I just threw this out here. I think many of us are struggling with this now. Should there be more preconception care that women actually plan their pregnancies together with their physicians, more REMS? Or should one avoid the use of teratogenic drugs in persons of childbearing age altogether to prevent this from happening? All of these are not great options, but I think we need to do something if we see those numbers. Limitations, obviously the study relies on accurate measurement of pregnancy, especially timing of conception. We have pretty good algorithms now, but gestational age is not always available in claims. So there's still a good amount of estimation that's happening here. We looked at the ICD-10 era only because that is better in this regard than the ICD-9 era. It relies on accurate measurement of drug exposure. The main analysis used specifically prescription fills and procedure codes for administration to avoid misclassification. An accurate measurement of prenatal care initiation. And as I said, this is a nationally validated measure that is used in the Child Core quality data set, quality improvement data set that is used on a federal level. And this is not generalizable to publicly insured persons, which we want to do next. So this is a population of privately and more affluent persons that we studied here. Thank you to my team. That's my pregnancy team, very strong team, and they all helped putting this together. We wanted to do this quickly because we really feel like these data need to be out there. So thank you.
We have time for a few questions.
Starts at some point. It's
Is it
private.
on? Yeah, it's on. Thank you for this work. This is incredibly provocative and timely. And I guess I would speak as a primary care physician who's also a pharmacoepidemiologist and someone who now sits on the FDA Disarm committee and has to review REMS. Is I'm really stunned by the lack of sort of awareness and publicity and enthusiasm I'm seeing for those long-acting reversible contraceptive options like IUDs and implants. So as we evaluated the isotretinoin REMS, it just felt like a number of people were like stuck in the past 20 to 30 years ago. I heard horribly sexist comments from some folks who, I won't say which group they were with, but talking about, we can't give young children IUDs. We're not talking about young children. We're talking about older teenagers and young 20-year-olds who have the right to choose longer acting contraception. So the idea that in a REMS plan, we need, even with REMS, we need to think not just about birth control pills or abstinence as options, but we need to really understand that long acting reversible contraception is so much more effective. And we don't want to argue any person who could become pregnant into birth control that isn't what they want, but we need to be making sure people are aware. And so I think, and I have fallen short too. I have seen women on ACE inhibitors and not had a conversation about pregnancy planning, but this needs to be built in. I would fall short of like a REMS for ACE inhibitors, but why is the first line antihypertensive recommended at my institution an ACE inhibitor and no mention of, and if you start it in someone under 45, you need to ask about contraception and document it.
Yeah.
So I would put out just a call in clinical care to EHR designers, to quality measures, that we need to document contraception conversations every year with women on teratogenic meds. And I don't know why this isn't happening.
So much agree, Sasha. I mean, oh my God, there's so much. And I actually reviewed the iPledge report for that from that 2023 FDA meeting to see what we have evaluated the iPledge REMS, and it doesn't work as well in teenagers as it works in 20-year-olds, which is understandable because they don't want to initiate probably commonly the discussion for contraceptive when their mom sits next to them with a dermatologist and so on, more risk-taking behavior whatsoever, right? There's so much going on. And I mean, that says you need to use two methods, right? So FDA doesn't really specifically identify the type of hormonal contraceptive. It only says you need a barrier method and something else, which of course nobody does, right? I mean, there's so many issues out there. I completely, and pre-pregnancy planning obviously only works if we are really looking at a planned pregnancy. If we know that 50% of our pregnancies are unintended, that doesn't really help either. There's so much to consider. In parallel in this room, Nicole is presenting on valproic acid. We actually looked at contraceptive use, and it's only 20% of all women who use contraceptives who are on valproic acid. That's her number. And we looked at LARCs as well with a 3-year look back, and it's minuscule.
Well, and I think we know that if we say we have to do preconception planning, I think that's a pipe dream, because I don't think we're going to get the majority of people in right before. But I do think, as a physician, the standard of care is that I see people once a year. I can't continue prescribing for them if I don't have a conversation once a year, right? Any chronic medication at least once a year, if not more, to ensure the disease is well controlled, there aren't side effects. And then I don't give them their renewal if I don't see them.
Yeah.
And so once a year is enough, maybe not quite enough, but we would see everybody every year and have the conversation.
Mm-hmm.
And this stuff could be built into EPIC.
Yeah. Yeah, yes. And I mean, and we do need we did evaluate the mycophenolate REMS, and, this was the same thing. You have long-term use, and women might have been told very early on when they started this drug that they shouldn't get pregnant. And that might not have been relevant to them at that time. And then they don't think about it anymore, and nobody tells them again, right? I mean, there's a lot to do.
Sorry, I know you're.
Questions now?
So you can't take
No, I would say perhaps offline if Almo is happy to.
I'm here.
Okay.
Okay, thanks, everybody. Thanks for all the questions. We're at 3, so we need to close it out, but thanks for coming to the
If anybody wants to quote this, the slides were not up. I mean, the slides are uploaded now, so I think there will be, because I really want these numbers to be quoted. I mean, the reason we made this study is so that this gets out there, so please use them.